and every one of you to the Clinpharm 2024 Congress on the theme Challenges in Medication Without Harm, Safety, Quality, and Rational Use. We're honored to have such a distinguished gathering of experts, professionals, and passionate advocates for medication safety. As we begin this session, I invite you all to take your seats. The inauguration ceremony is shortly, and we have a wonderful program lined up for you, filled with exciting speeches and lively discussions. Thank you for joining us, and once again, a very warm welcome to you all. Please remain standing for the national anthem. We will now proceed with the lighting of the oil lamp, and I would like to invite the following dignitaries to join the lighting of the oil lamp. Our chief guest, Dr. Palith Mahipala. The guest of honor, Professor Simon Maxwell, representing the British Pharmacological Society. The orator, Professor Caroline Seymour, representing the International Union of Basic and Clinical Pharmacology. The president of SLACPT, Professor Pridarshini Galapatti. The president-elect, Professor Chandani Vanigatunge. Immediate past president, Professor Asita De Silva. President of the Sri Lankan Medical Council, Professor Vajira H.W. Disanayake. Additional Secretary of the Ministry of Health, Dr. Sunil De Alvis. The Deputy Director of General Medical Services, Ministry of Health, Dr. Lal Panapitiya, Dr. Mahesha Nadugala, representing the National Science Foundation, the Secretary, SLACPT, Professor Priyanka Ranasinghe, and the Treasurer, SLACPT, Dr. Sujivani Kurukulasuri. Now I invite our chief guest of honor, the orator, president, and the secretary to come to the head table. It is my pleasure to invite Professor Priyadarshini Galapatti, President of SLACPT and Senior Professor of Pharmacology at the University of Colombo, to deliver the welcome address.
Good morning, Dr. Palith Mahipala, chief guest for this morning, Professor Simon Maxwell, guest of honor, Professor Caroline Sermon, our orator, Professor Vajra Disanayaka, President, Sri Lanka Medical Council, members of the SLACPT Council, distinguished invitees, esteemed colleagues, dear friends, ladies and gentlemen. It is my pleasure and privilege to welcome you all to Clinpharm 2024, a landmark event held in collaboration with the International Union of Basic and Clinical Pharmacology. This year's conference promises to be an inspiring gathering of minds dedicated to advancing clinical pharmacology and medication safety. First and foremost, I extend a warm welcome to our chief guest, Dr. Palith Mahipala, Health Secretary of Sri Lanka. Sir, your presence here is especially significant as you were also our chief guest at our inaugural academic session of SLACPT in 2016 when you were the Director General of Health Services. Your continuous support signifies the importance of our shared mission to enhance healthcare standards, particularly your commitment to improve the medication safety and pharmaceutical situation in Sri Lanka. I'm equally delighted to welcome our guest of honor, Professor Simon Maxwell, Professor of Clinical Pharmacology and Prescribing at the University of Edinburgh, UK. Your keynote address will undoubtedly set the stage for a thought-provoking conference on medication safety and clinical pharmacology. We are particularly happy to re-establish links with the University of Edinburgh because our first professor of pharmacology, Professor Senaka Bibile, who is well known globally for his pharmaceutical policies, obtained his PhD from the University of Edinburgh, and our own secretary, Professor Priyanka Ranasinghe, recently had his clinical training in clinical pharmacology in Edinburgh. It is also my absolute pleasure to welcome Professor Caroline Samer, Professor of Pharmacology and Clinical Toxicology at the University of Geneva, Switzerland, with whom I have worked closely on medication safety through my affiliation with the WHO. We look forward to your oration, Caroline, on your outstanding research work that you have done in the field of pharmacogenomics and the relevance of that to medication safety. I also take this opportunity to congratulate you for being elected to lead the IUPHAR Next, and I thank you immensely for your invaluable support in organizing this conference in collaboration with IUPHAR, which enabled us three esteemed experts, you from Switzerland, Lauren from UK, and Nilima from India, to joining us in Colombo as resource persons, enriching our discussions. We are excited to announce that we have plans to introduce prescribing safety assessment similar to the assessment in the UK in collaboration with the British Pharmacological Society. I warmly welcome Professor Vajira Disanayaka, President of the Sri Lanka Medical Council, who has been immensely supportive of this initiative. Yesterday, we had an extremely useful and excellent workshop conducted by Professor Simon Maxwell and Ms. Preeta Wright from the British Pharmacological Society, which helped us to understand more about the operational aspects of this assessment and to develop questions suited for Sri Lanka. The importance of this conference cannot be overstated, as medication safety is the most common preventable cause of patient harm globally, with about nearly 50% of all medical errors accounted for by medication errors. In 2017, the World Health Organization launched the Global Patient Safety Challenge, Medication Without Harm, aiming to reduce the severe avoidable patient harm globally. Our conference theme, Challenges in Medication Without Harm, Safety, Quality, and Rational Use, will highlight the burden of medication-related harm and the approaches to address it based on the WHO strategic framework. The Sri Lanka Ministry of Health launched the National Action Plan on Medication Safety, developed on the WHO strategic framework through the Directorate of Healthcare Quality and Safety. I warmly welcome Dr. Lal Panapitiya, Dr. S. Sridharan, Dr. Upuli Vijayamana, and other Ministry of Health officials who helped us in developing and launching this National Action Plan, and who continue to help us in implementing medication safety activities in the country through the Ministry of Health. We hope this conference will consolidate the successful implementation of the National Action Plan by all stakeholders who are joining this conference today. I also extend a warm welcome to all the delegates from the WHO Global Patient Safety Collaborative countries, India, Pakistan, Mongolia, and Ethiopia, who have joined us today. We hope you will find many ideas and insights through the deliberations during the conference and the post-Congress site visit to a medication safety demonstration site in Colombo that could help to improve medication safety in your respective countries and globally. Education on medication safety in undergraduate curricula for doctors, pharmacists, and nurses is critical, as prescribed medicines by doctors are dispensed by pharmacists and administered by nurses. In 2021, we took steps to introduce the WHO medication safety curriculum to medical curricula through the Directorate of Healthcare Quality and Safety, with the help of members of our association in all medical faculties in the country. Now we are planning to do the same for pharmacy and nursing curricula using the updated WHO medication safety curriculum guide. I give a warm welcome to all nursing and pharmacy educators who are participating today and request to address the medication safety in your curricula using the updated WHO curriculum that will be published soon. We also have many participants from the private sector hospitals and pharmacies, including doctors, nurses, and pharmacists joining this conference. And I welcome all of you and hope this conference will help you to initiate activities on medication safety in the private sector, which is an integral part of our healthcare system. Professor Vajra Disanayak, as president of the SLMC, and the Ceylon Medical College Council is taking a lot of efforts, especially to improve training of pharmacists in the private sector, and we took extra efforts to involve them in this conference. Our conference program is packed with enriching sessions, including plenaries, symposia, and panel discussions addressing the WHO Global Patient Safety Challenge, Medication Without Harm. We will delve into the 4 domains and the 3 action areas of the WHO strategic framework, explore the medication safety curricula, and examine prescribing safety assessments and country experiences during the many plenaries, symposia, and the panel discussions that are organized during the 2 days. The high-quality research presentations during oral and poster sessions will provide much-needed evidence on important aspects on clinical pharmacology and medication safety. We can learn from each other, and in the session on sharing experiences, we will learn about medication safety initiatives in the UK, Switzerland, India, and Sri Lanka, including how we are implementing activities at the hospital level with limited resources. The post-Congress workshop on rational and effective prescribing on the 16th July needs a special mention. The SLACPT has developed many guidelines and monitoring mechanisms, collaborating with other relevant specialist colleges as an initiative through the SLMA Intercollegiate Committee on the use of medicines that cost most in our drug budget, such as tenecteplase, IV immunoglobulin, human albumin, and factor VIII, on which we are spending over 4 billion rupees annually. We also developed guidelines guidelines on the commonly used OPD medicines, which was actually a suggestion by the Secretary Health, and we are also developing the monitoring mechanisms to implement these guidelines through the respective colleges. And I give a warm welcome to all the, to many of the colleagues who have joined us in numerous subcommittee meetings that were held to develop these guidelines. Discussions on health technology assessment on how to identify cost-effective medicines for our country also will be discussed during the workshop, which will help immensely to manage the drug budget and avoid medicine shortages in the future. This conference stands out for its inclusive approach. We have actively involved pharmacy and nursing professionals from both the government and the private sector in this conference. By working together, we aim to implement medication safety initiatives across both government and private sector, involving these healthcare professionals, ultimately benefiting our patients. Lastly, I would like to extend my heartfelt appreciation to our highly efficient Secretary, Professor Priyanka Ranasinghe, for his energetic leadership, as he will not be thanking himself in his vote of thanks. I had the best team to organize this event with Professors Pradeepa, Chandani, and Dr. Sujivani, Charanti, Leonard, and Ramesh taking the brunt of the organization, supported by all others, and I'm deeply grateful for all your contributions. Thank you. Let us embark on this journey of knowledge, collaboration, and innovation together to ensure safe use of medicines locally and globally. Once again, welcome to Clinpharm 2024. Thank you.
Thank you, Madam, for that warm and insightful welcome. Your dedication to pharmacology and medication safety is truly inspiring. Next, we have the keynote address by our esteemed guest of honor, Professor Simon Maxwell, Medical Director of Prescribing Safety Assessment of the British Pharmacological Society, and the Professor of Clinical Pharmacology and Prescribing at the University of Edinburgh. Please allow me to invite our President, Professor Galapathy, to introduce our guest of honor.
Professor Simon Maxwell is Professor of Clinical Pharmacology, Student Learning and Prescribing at the University of Edinburgh, UK, and Director of Clinical Pharmacology and Therapeutics Teaching at the same university. He is a Medical Director of the Scottish Centre for Adverse Reactions to Drugs, CARDS. He was formerly Vice President of the British Pharmacological Society and Clinical Lead for the Prescribe Project. He is Medical Director of the Prescribing Safety Assessment, a joint initiative of the British Pharmacological Society and Medical Schools Council in the UK, delivering a national assessment of prescribing for all UK medical students. He is past chair of British Pharmacological Society Prescribing Committee and the lead author of BPS co-curriculum for clinical pharmacology and therapeutics. He was chair of the European Association of Clinical Pharmacology and Therapeutics Education Committee and also the co-lead of the Pharmacology Education Project of the International Union of Basic and Clinical Pharmacology. Over to you, Professor Simon Maxwell, to deliver your keynote address.
Honourable guests, distinguished colleagues, ladies and gentlemen, it's my profound honour and privilege to be invited to be the guest of honour at this esteemed international clinical pharmacology meeting here in the beautiful and culturally rich nation of Sri Lanka. We gather as a diverse community, but yet unified by our interest in the and commitment to the sharing the science and advancing the science of clinical pharmacology and improving patient care worldwide. So Sri Lanka, with its rich history of medicinal practices and burgeoning healthcare landscape, provides a fitting backdrop to these discussions. This meeting's a testament to the global collaboration that has always characterized the field of clinical pharmacology and brings together minds from around the different corners of the world to exchange knowledge, share insights, and forge new pathways in clinical pharmacology. So, of course, clinical pharmacology stands at the intersection of a number of different disciplines, encompassing those that we traditionally think of when we think of clinical pharmacology, such as pharmacokinetics, pharmacodynamics, and therapeutic drug monitoring, to mention just a few. But of course, we're part of a science which is on an exciting cusp of leaping forward, largely because of the advances which have been made in pharmacogenomics. And our work is crucial in bridging the gap between laboratory research and patient care, ensuring that new medications are both safe and effective. And as we gather here, we're reminded of our responsibility that we bear in our quest to improve therapeutic outcomes and reduce the incidence of adverse drug reactions. And we do all of that because of the patients that ultimately we as scientists and clinicians serve. So with the rapid advances in technology and science that are part of clinical pharmacology present us with new and unprecedented opportunities. The rise in particular of precision and personalized medicine, which we're going to hear a lot about later, now allows us to tailor treatments to individual patients based on their genetic profiles. This personalized approach not only enhances efficacy, but hopefully will also minimize the risk of adverse effects, which we all recognize are particularly common in clinical practice, and in that way will pave the way for effective and safer therapeutic options for patients in the future. Our challenge, therefore, is to harness these advantages and integrate them into everyday clinical practice, ensuring that every patient can benefit from the latest scientific discoveries. So moreover, the global nature of our field necessitates a collaborative approach. Diseases do not recognize borders, and neither should we in our efforts to combat them. By fostering international collaborations, we can pool our resources, share our expertise, and address the global health challenges that affect us all. So this meeting serves as a platform for this kind of collaboration, where we can learn from each other's experiences and build networks that transcend geographical boundaries. So in the context of global health, we must also acknowledge the very serious disparities in healthcare access and quality that exist across different regions of the globe. As clinical pharmacologists, we have a role to play in addressing these inequalities. By conducting research that is inclusive and representative of diverse populations, we can, in the future, help to develop treatments that are effective for all patients, regardless of their background. Additionally, by advocating for policies that promote equitable access to healthcare, we can help to ensure that the benefits of our scientific advances reach those who need them most. As a particular interest, education and training are also vital components of our mission. We must invest, firstly, in the next generation of clinical pharmacologists, providing them with knowledge, skills, and mentorship they need to thrive in this dynamic but also challenging and fast-moving field. By fostering a culture of lifelong learning, we can ensure that our workforce remains at the forefront of the scientific and clinical innovations that clinical pharmacology delivers. Moreover, as well as educating ourselves and the next generation of clinical pharmacologists, we must think of those people who actually are the agents that make sure that the advances that we create through our science are actually delivered on the ground in healthcare settings. And that's why, on a personal level, I've always been interested in how we transmit the knowledge and skills of clinical pharmacology to those who are not clinical pharmacologists, but actually use the skills and principles of clinical pharmacology every day, particularly prescribers on ward settings, but also those who supply and administer medicines as well. If we can actually try and make sure that those people have a small understanding of clinical pharmacology and the drugs that we use, then hopefully that will enable safer healthcare for the patients that we have. Because ultimately, in terms of governance and quality of healthcare, it is use of medicines that really is one of the most influential ways forward. And that's why I'm particularly happy that this meeting marks the very beginning of a collaboration between the UK and Sri Lanka in delivering a prescribing skills assessment, which I think has been so important and influential, not just for improving clinical care in the UK, but also increasing the strength and the health of the specialty of clinical pharmacology. So in closing, I'd like to express my gratitude to the organisers of this meeting for their hard work and dedication. Those organisers will be many, but it's Priya Dashani, Priyanka really, who I've had a particular lot of dealings with over the last few months, and I know you've worked particularly hard to make sure that we're all here healthy, happy, and indeed also entertained in this room today. I'm confident that the discussions and collaborations that emerge from this gathering will contribute significantly to the advancement of clinical pharmacology and the betterment of global healthcare. So let us take this opportunity to learn from one another, to inspire and be inspired, and forge a future where every patient is able to access the best possible care. So thank you very much for your invitation to be part of this meeting, and I look forward to fruitful discussions ahead.
Thank you, Professor Maxwell, for your enlightening keynote address, highlighting the crucial need for prescribing safety and the role played by clinical pharmacologists in minimizing medication-related harm. Now, I invite Professor Pridarshini Galapatti to introduce the chief guest, Dr. Palith Mahipala.
Dr. Palith Mahipala is the current Secretary to the Ministry of Health Sri Lanka. He's a specialist in medical administration and has had an illustrious career as a medical administrator. He has served as the Additional Secretary, Medical Services and the Director General of Health Services, Sri Lanka previously. He was also the WHO representative and head of the mission in Pakistan that he has served prior to taking up the important post as the Secretary Health in our country. He has held membership of many advisory committees and director boards of international and national bodies, including the Global Fund, Switzerland, and Gavi Secretariat. He was awarded the Global Ambassador Award in 2022 for the outstanding work done for the well-being of people in Pakistan. Over to you, sir, to address the gathering.
Thank you so much for those kind words of introduction. Good morning to everybody. The President of the Sri Lanka Association of Clinical Pharmacologists and Therapeutics, Senior Professor Priyadarshini Galapatti, the guest of honor, the orator, all the other distinguished invitees, and council members, dignitaries from the Ministry of Health, colleagues and friends, ladies and gentlemen. I have supreme honor, remarkable privilege, and great pleasure in standing before you in this wonderful occasion, in this august gathering, to share some of my views and thoughts at this wonderful occasion of the inauguration of the annual scientific sessions. I'm delighted to see some of the most senior, esteemed, and respected members of the medical fraternity, such as Professor Geeta Fernandu, Professor Serif Dean, Dr. Sarath Gamini is also present here, which highlights that this event has been recognized as one of the most important events by the medical fraternity in Sri Lanka as well. I'm delighted to see the Sri Lanka Medical Council President and some of senior medical administrators also present here today. Let me start with some figures on an article which I read some times back. The article was on the risk involved with different events. It went on to say that if somebody travels by air, the risk involved for death is 1 in 3 million. The risk involved is 1 in 3 million. And if somebody travels by sea, risk is little higher. And if a person travels by road, we all know the risk involved. In Sri Lanka, road traffic accident kills 6,000 people annually. That's quite high. Then, of course, climbing mountains, scuba diving, risk is much more. And finally, it highlights staying in a hospital has the highest risk, even much more than all the others, which comes to 1 in 300. And that highlights that as government, Ministry of Health, and medical professionals, we need to really focus our attention on the patient safety. Is our hospital where we are working is safe for the patient to come and get the treatment? And the World Health Organization was very much focused on patient safety. And there's a separate department, and annually there's a day to commemorate the activities of the patient safety. And we have a patient safety day every year, commemorated by all the countries and all the ministries of health. And during 2022 Patient Safety Day, there was a dedicated publication by the World Health Organization, which highlights 1 out of 10 who comes through our hospitals has some errors. And they are being suffered due to medical errors, 1 in 10. 1 in 30 get a medication errors. And today we are talking about safety without medication errors and care without medication errors. So 1 in 30 who goes through our system gets some complication due to inappropriate medication. And 3 million deaths taking place annually globally due to patient errors, 3 million. and Professor Sharifdeen is here, 300 million surgeries are done globally, annually, and out of which 10% ended up in complications due to errors. 16 billion prescriptions are done annually, and 30-40% are inappropriate. So therefore, we are talking in a context where patient safety is important. Within that, the medication errors has to be considered as one of the area where we need to work very hard. So therefore, I'm delighted to see that the Clinical Pharmacologists Association in Sri Lanka is taking this as the topic for the annual academic sessions, and then taking measures to ensure the patients who are coming to our institutions are safe. Also, WHO further stated that 70% of injections given in the primary healthcare institutions have no use. 1 out of 4 medication given to patients are inappropriate. So this is the area we are dealing with. And I am delighted today that this forum is taking place at a time that the Ministry of Health is undertaking health sector reforms. We are focusing on primary health care reforms. Again, the medication errors, medication safety will be part of it. We are undertaking to have different structures and organizations within the Ministry of Health to ensure more patient safety. And we are transforming the Quality Secretariat to a Patient Safety and Accreditation Bureau. And we are going to embark upon accreditation in Sri Lanka, working very closely with the Australian Accreditation Association, and then of course started training our assessors and embark upon a program. We already prepared the cabinet paper and submitted for the cabinet approval to move forward with a new structure to ensure that accreditation is taking place. Now, why we are talking so much of medication, Sri Lankan community, and it is common for the global community as well, is undergoing transitions. We have demographic transition, we have witnessed it. The fastest aging population in whole Asia is in Sri Lanka. And in another 15 years' time, we will have 1 out of 4, or 25% of the population is above 60 years. Then the epidemiological transition, CDs are coming down. Sri Lanka was able to eliminate malaria in 2016. We got the WHO certification for that. We were able to eliminate filaria from the soil, and we got the certificate. We were able to eliminate measles, mother-to-child transmission of HIV. We were able to eliminate many diseases, neonatal tetanus in 1993, polio in 1994. So we able to deal with the communicable disease much comprehensive way. But now the challenge is elderly population, and the chronic diseases are coming up as a result of epidemiological transition. And we see the lifestyle transitions, diet transition. There are so many other transitions taking place as a result, more and more NCDs and more chronic diseases. Day before yesterday, when I was in the office, I got a message from one of my administrators saying that one of our colleagues, who was the deputy director in rehabilitation hospital, passed away due to an infarction. And we had a walk in for scoliosis 2 weeks back, started from at LRH, and we met the IG, the Inspector General of Police, and he said, last year, 52 senior police officers died due to heart disease, prematurely. All these deaths are premature. Ladies and gentlemen, Madam President, globally there are 55 million deaths taking place annually, out of which 41 million deaths are due to non-communicable diseases. Out of that, 17.9 million deaths are due to cardiovascular diseases. Close to 10 million deaths are due to cancers. 4 million deaths are due to chronic obstructive airway diseases, and 2.4 million deaths are due to diabetes. So all chronic diseases, and out of which 4 out of 10 are premature deaths before 65 years. When people die early, one of the medical administrators who are qualified with MSc and MD, how much of money we have invested on him. And senior police officers, where the government has spent so much of money. Think about a senior professor die in 45, 50, how much of money we spend. That will have a huge economic impact on the country as well for the development. So therefore, these chronic diseases are very important to deal with. So that's why we thought that we will go for primary healthcare reforms to deliver integrated healthcare services for elderly care, rehabilitation. As I said, 6,000 deaths due to road traffic accidents, and few hundred thousands are ended up in disabilities. And then, of course, hypertension is quite prevalent, 4.2 million in the country. 48% of adult population have hypertension, and only 18% having a good control. As a result, 60,000 stroke are reported to the Ministry of Health. Private sector may be equal number. 4,000 die, 56,000 ended up with some disabilities. So rehabilitation is a very important area. So our integrated healthcare delivery at the primary healthcare level, we are focusing on NCD, we are focusing on elderly care, we are focusing on rehabilitation, we are focusing on palliative care where the cancers are much on the increase. WHO has predicted by 2030, the number of deaths due to cancers will be overtaken, the deaths due to heart diseases. So this is the society we are living. So in that, of course, when there are chronic diseases, it's not like sometimes back where we deal with acute diseases, we have to use medication. And the people who have hypertension, heart disease, will continue lifelong treatment. And malaria is one episode you treat, 1 week treatment is cured. But hypertension is not so. Kidney disease is not so. Diabetes, it's not so. So we are dealing with much more medications. In 2016, when I left the country, we had 45 billion set apart for medication, 45 billion Sri Lankan rupees. And today, the medication, the allocation for pharmaceuticals are 187 billion, six-fold increase. You can imagine this is a very important area. So I don't want to go into detail how we are going to do that. And we have started some interventions to ensure medication safety. And some hospitals, they are doing very well. So we need to scale it up, expand it to the whole country, ensure that each and every patient coming to our system is safeguarded when it comes to prescription of drugs. And also we see that consumption of pharmaceuticals or drugs, medicines are quite high in Sri Lanka. The utilization of health services is quite high. One citizen in the country visit to a healthcare institution 6 times a year. Many other countries, China it is 3, Bangladesh 2.3, many other countries much less than 3, but we are 6. And when it comes to hospital admissions, the highest hospital admissions are in Sri Lanka for 100,000 population, not even in developed countries where chronic diseases are prevalent. So we have to look at the system and ensure that there's no medication errors, probably maybe 20-25% of readmissions coming back to OPDs are due to medication errors. So this is a very important area. I am so much delighted that you have taken it up, and we are very much happy that Professor Piyadashini Galappatti, who is one of the most eminent professors in pharmacology, is involved in that. She is helping the Ministry of Health, and I am sure that during the course of the day, today and tomorrow, there will be deliberations, sharing best practices, how to deal with this, and we are very much happy that your recommendation will come to the Ministry of Health for us to take policy actions. And the same venue today, where we are meeting here, on the other side, we have 9 years celebration of the establishment of National Medicinal Regulatory Authority, NMRA. And there, of course, we are going to remind about the excellent work done by Professor Senaka Bipile, who is one of Sri Lankan professor of pharmacology, who has done so much of great work. So this high time that we focus on medication errors and move forward. So we wish you all the very best. I extend my sincere thanks and gratitude to Professor Piyadashini Galappatti for inviting me to witness this event and learn something from you all. And I am sure that after the deliberation of 2 days, you will come out with a set of recommendations for the Ministry of Health to take necessary actions. I wish your deliberation all success. I stop here. Thank you so much.
Thank you, sir, for highlighting the critical issue of medical errors and the importance of improving safety measures. We are honored to have Professor Caroline Sammer, delivering the SLACPT oration on precision medicine and pharmacotherapy, right drug at the right dose for the right patient. May I now invite Professor Galapati to introduce the orator and award the orator's medal and certificate.
Thank you. Before I introduce Professor Caroline Sama, I would like to thank Dr. Palith Mahipala for your excellent talk, sir. And coming that address from the Secretary of Health is, I'm delighted that you have understood the importance of medication safety and your understanding of the needs for the pharmaceutical sector in Sri Lanka. And we are very happy to give you all the assistance from our association to improve medication safety and the pharmaceutical situation in Sri Lanka. And I would also like to, I started my medical career under Professor H. Sharifdeen. I'm so happy that to see you in the audience. Thank you. So, and it gives me great pleasure to introduce Professor Caroline Sama, our SLACPT orator for 2024. Professor Caroline Sama is a professor of clinical pharmacology and toxicology at the University of Geneva, Switzerland. She obtained her medical degree in Geneva in 2001. After specializing in internal medicine and clinical pharmacology and toxicology, she completed a doctorate in pharmacogenomics, followed by a postdoctoral fellowship in molecular pharmacology in Sydney. Her research focuses on personalizing drug therapy and making it safer using precision medicine approach by measuring gene, environment, disease interactions at pharmacokinetic level and by exploiting advances in various biomic technologies, particularly pharmacogenomics. Following her postdoc, she returned to the University Hospital Geneva in 2009, first as a senior clinical associate, then attending physician and head of the Therapeutic Information Center in the Division of Clinical Pharmacology and Toxicology. In 2019, she took over the responsibility of pharmacogenomics and personalized therapy unit and later was appointed head of the University Hospital Geneva, Division of Clinical Pharmacology and Toxicology. She is also the academic director of the Department of Anesthesiology, Pharmacology, Intensive Care and Emergency Medicine, Geneva University. She is a member of the Dean's Office of the Faculty of Medicine of the University of Geneva. She is currently the president of the Swiss Society for Clinical Pharmacology and Toxicology, as well as the president of the Swiss Society of Pharmacology and Toxicology, which is the Swiss umbrella society for the 4 pharmacology and toxicology societies, and the vice president of Swiss Ethics Committee. She is a council member of the European Association for Clinical Pharmacology and Therapeutics. She is former chair of the Clinical and Translational Section of the International Union of Basic and Clinical Pharmacology, IUPHAR, and the president-elect of IUPHAR. She also functions as the focal point at IUPHAR for the World Health Organization. And it is my absolute pleasure to invite you to deliver the oration, Caroline. Sorry, I need to award her the orator's medal and the certificate before she delivers the oration.
Distinguished colleagues, dear guests of honors, dear speakers, participants, ladies and gentlemen, Ayu Bowen. On behalf of IUPHAR, I would like to warmly thank and congratulate the SLACPT and in particular Professor Priya Galapati, its president, and Professor Priyanka Ranasinghe, the secretary, as well as all council members of SLACPT for organizing Clinpharm 2024 on such a crucial theme, being challenges in medication without harm, safety, quality, and rational use. Advancing medication safety and the rational use of drug is a core aspect of IUPHAR mission, which aligns with the WHO Third Global Patient Safety Challenge, Medication Without Harm. IUPHAR is therefore delighted to co-organize such a crucial event to exchange knowledge and share best practices in medication safety. I am deeply honored to have been invited to give the SLACPT 2024 oration, and I hope to show you that precision medicine is of the utmost importance when it comes to drug safety and efficacy, which is why I called my talk Precision Medicine and Pharmacotherapy, the right drug at the right dose for the right patients. So I'm sure you're all aware that there's a huge variability in drug response. When you see patients in the clinic with the same diagnosis, most of the time you give them the same drug. And some of them will respond to the drug the way you'd like to. The drug is effective, non-toxic, but unfortunately, some of them will experience toxicity, others will experience inefficacy, and worst case scenario, I must say, is when the drug is both ineffective and toxic. An adverse drug reaction is a crucial burden worldwide. It's well known from the literature that 5 to 10% hospital admissions are due to adverse drug reactions. It's the fourth cause of death in the US, and it costs $4 billion. But importantly, 50% of those cases are preventable. Medicine is quite imprecise at the moment. You see here a graph that shows you the top 10 best-selling drugs in the US in 2015. In blue, you see, in pink, you see the number of people that needs to be treated for one person in blue to benefit from it. And looking at very frequently prescribed drugs such as esomeprazole, a proton pump inhibitor, or rosuvastatin, anti-cholesterol lowering drug, you see that 20 to 25 people have to be treated for one person to benefit from the drug, which makes the traditional one-size-fits-all approach being fundamentally challenged. We differ from one another, and there should be a paradigm shift from one-size-fits-all strategy to personalized therapy. There are different sources of variability in drug response. The classical source of variability that we well know are intrinsic factors: weight, age, sex and gender, comorbidities, organ functions. There are also environmental factors. As clinical pharmacologists, we look at co-medication, but there are also herbal medicines, smoking, alcohol, diet, etc. And more, we look at genetic factors as well. And precision medicine is actually an emerging approach for the treatment and prevention of disease, which takes into account the variability of individuals, both at the level of their genes, their environment, and their lifestyle. In 2015, President Obama launched the Precision Medicine Initiative. The aim was to lead a new era of medicine, one that delivers the right drug at the right time. So why was it launched 10 years ago? Because the time was right. The sequencing of the human genome was done, and the cost per genome decreased dramatically. You see that in 16 years, to sequence a genome, it dropped from 100 millions to less than $1,000. We have improved technology for biomedical analysis, and we have new tools for using large data sets. We all hear about artificial intelligence, of course, but we have also mobile devices to quantify health, and of course we have also the electronic health records. So we have been facing a genomic revolution, but also with the development of health informatics systems, imaging, data universe, wireless sensors and devices, mobile connectivity, social networking, and internet, we should be able to better prevent, predict, manage, and diagnose diseases. The Precision Medicine Initiative in the US aimed to create a research cohort of more than 1 million American volunteers. And in that cohort, one of the aims was to advance pharmacogenomics. So what is pharmacogenomics? Pharmacogenomics is the study of the influence of genetic variation on drug response. The objective of pharmacogenomics is to individualize drug therapy. The ultimate goal would be to improve the effectiveness of treatment, to reduce the incidence of adverse events, and of course, we hope to reduce the cost of the treatment to the healthcare systems. So when we talk about pharmacogenomic factor, what factors have we in mind? We have in mind factors that can have an impact on the pharmacokinetic. So for those of you who are not clinical pharmacologists, I remind you that the pharmacokinetic is what the body does to the drug. So it's absorption, distribution, metabolism, excretion. So there are genetic factors on drug transporters, on drug metabolic enzymes. And there are also pharmacogenomic factors on the pharmacodynamics, so the targets of the drug, receptors, ions, channels, etc. The probably most studied pharmacogenomic factor, the pharmacogenomic factor impacting drug metabolizing enzymes is what's the most studied, and in particular cytochrome P450s or CYP. So I will go through 3 examples to show you that precision medicine and pharmacogenomic is not the future, it's already the present in some countries, and it should be the case as well in Sri Lanka. First example is the example of codeine. You might have heard that codeine should not be prescribed anymore in children. Codeine is a painkiller and a cough suppressant. Why has codeine been banned in several countries in children? Because codeine is metabolized, is transformed by CYP2D6, by that enzyme cytochrome P450 isoform 2D6 into morphine. So you have here the chemical structure of codeine. Codeine is transformed into morphine, and you see that the main difference between codeine and morphine is an O-demethylation, and that O-demethylation converts a drug, a prodrug that's ineffective against pain, against morphine, that is the opioid you all know. But it's important to remember is that CYP2D6 is a polymorphic enzyme. When you carry 2 genes with normal activities, you have an activity score of 1.5 to 2, your enzyme is normal, and the metabolism is normal. When you carry duplication of the genes, the activity score is higher than 2, the enzyme is surexpressed, and you're what's called ultra-rapid metabolizer of CYP2D6. On the other way, if you carry 2 genes with no activity or a deletion of the gene, the activity score is 0, you do not have any enzyme, and you're a poor metabolizer of CYP2D6. And there's an intermediate category called intermediate metabolism with an activity score between 0.5 and 1.25, where the enzyme is not totally absent but is not working fully properly. The frequency of those different polymorphisms in Europe is as follows: up to 10% ultra-rapid metabolizer, depending on where people live in Europe. There is a higher frequency of CYP2D6 ultra-rapid metabolizer in the south of Europe and in the Mediterranean region. 5 to 10% poor metabolizer, and 10 to 15% intermediate metabolizer. In South Asia, you see that the frequency is quite different. In South Asia, intermediate metabolizer are more important than in Europe. It's 40%. So what happens when CYP2D6 is not working? Well, codeine is not converted into morphine. And we showed that 30 years ago in my department. We showed giving to healthy volunteer codeine. Those healthy volunteers who were poor metabolizer of CYP2D6 were not producing morphine. And those who were given quinidine, which is a CYP2D6 inhibitor, they were not producing morphine either. What is the clinical consequence? we first tested in healthy volunteers the impact of such a reduction of morphine production, and we showed that there was a reduced analgesic efficacy in healthy volunteers who were poor metabolizer. I show you here results of a study in women who had C-sections. They were treated with codeine, and those women, they were genotype for CYP2D6. And you see here the median dose of codeine over 3 days. The normal metabolizer of CYP2D6 received 180 milligram, while the poor metabolizer of CYP2D6 received 450 milligrams. So they required 2.5 times higher doses. Probably even that dose was not sufficient for them. On the other hand, when CYP2D6 is too active, when you are an ultra-rapid metabolizer, you will produce too much morphine. And unfortunately, when you produce more morphine, the risk is increased toxicity. And you see here a list of case reports that were published in the literature where, unfortunately, giving codeine to ultra-rapid metabolizer children had dramatic consequences. You see that several children, unfortunately, died from taking codeine just after having adenotonsillectomy, or even a mother who was breastfeeding. She was a CYP2D6 ultra-rapid metabolizer, and she produced too high level of morphine that passed into the breast milk, and unfortunately, a child died. So all these cases had in common to be ultra-rapid metabolizers of CYP2D6, which is why the FDA and the European regulation progressively released safety communication regarding codeine use in nursing mother. Then they contraindicated codeine after tonsillectomy and adenoidectomy. Then they restricted the use of codeine for pain and for cough in all children and breastfeeding women. And in 2018, they requested a labeling change so that those so that codeine is not used in adults younger than 18 years of age. The same recommendation was made by the European Medicine Agency and in Switzerland as well. There is a consortium called the Clinical Pharmacogenetics Implementation Consortium, CPIC, that meets regularly and draw guidelines for different drugs. So this is the guidelines that was updated in 2021 for codeine. And the guideline says that in ultra-rapid metabolizer, codeine should be avoided, and in poor metabolizer, codeine should also be avoided. And in Europe, that's 1 in 5 Europeans that should not receive codeine either due to inefficacy or toxicity. So if you want to know more about these genes and the impact on different drugs, you can go on the PharmJKB website, where you typed the drug codeine, and then you typed pharmacogenomics prescribing information, and depending on the genotype of the patient, you get the recommendation. So I've talked about codeine, but you have to remember that codeine is not the only prodrug out of all the opioids. You see here a list of prodrugs that needs to be bioactivated by CYP2D6 in order to be active. And you see that's also the case for tramadol, hydrocodone, oxycodone. Tramadol is converted by CYP2D6 into an active metabolite. And you see here a study in patients after major abdominal surgery. You see that the same thing happened than with codeine. Poor metabolizer, they require much higher doses of tramadol than intermediate, normal, and ultra-rapid metabolizers. And actually, poor metabolizers, they have a quadrupled therapeutic resistance to tramadol. They require rescue medications 4 times more frequently than other genotypes. But tramadol is not exactly the same drug as codeine. Tramadol, the mother molecule, has monoaminergic properties. If you look at the chemical structure of tramadol and the chemical structure of an antidepressant called venlafaxine, you see the close similarities between these two drugs, which doesn't surprise you to know that tramadol is actually monoaminergic. So the problem with tramadol is depending on the genotype of your patient, you're not sure which drug you are actually giving. In a poor metabolizer, you are actually administrating antidepressants that's quite active with the risk of serotoninergic syndrome. And in an ultra-rapid metabolizer, the patient will produce more opioid, and you have the risk of opioid toxicity. So 2 phenotypes and 2 different drugs, which is why we warned the community of prescriber against the use of tramadol prescribing in children, because in the US, both codeine and tramadol have been banned in children, but in several countries, including Europe, because codeine has been banned, the pediatrician, they prescribe tramadol instead, and this is not a good idea. Second example is the example of the statins. You all know those lipid-lowering agents, and you know as well that these statins can cause muscle damage in 5 to 10% of patients. And those muscle damage, they can lead to fatal rhabdomyolysis in 1.5 cases per 10 million. This is a dose-dependent adverse drug reaction. So we could do a pharmacogenetic study looking at the way statins are metabolized. Statins are metabolized by CYP3A, by CYP2C9, and look at whether those polymorphisms lead to difference in drug response. But another way to do a pharmacogenomic study is not to fish for one mutation, but it's to go fishing for several mutations, thousands of mutations, by doing what's called a genome-wide association study. So that's what some authors did. They performed a genome-wide association study in patients that were taking simvastatin, 80 milligram. Out of these patients, 85 developed a myopathy, and they matched them with 90 controls. In all those patients, they performed the genome-wide association study looking at 300,000 genetic markers. And this is how the results look. It's what's called a Manhattan plot, because it's like buildings. And you see here on chromosome 12 that there was one significant mutation that was able to explain why patients developed myopathy. That mutation was a mutation of the gene called SLCO1B1, mutation star 5. And having that mutation increased the risk of myopathy by 17 times if you carry 2 mutations. That mutation explained 90% of myopathies. And those results were then replicated in other data sets. So what is SLCO1B1? SLCO1B1 is a gene that encodes for a transporter called organic anion transporter 1B1. You see here where is the OATP1B1. It facilitates the transport of the statin into the liver, into the hepatocytes. And there are several mutations of that SLCO1B1 gene, the most common being SLCO1B1 star 5. So I found some studies done in Sri Lanka, and that study specifically looked at the prevalence of the SLCO1B1 star 5 in Sri Lanka. And you see here the frequency in Europe versus Sri Lanka. What's interesting is that the variant homozygotes, so the patients that are particularly at risk of myopathy after taking a statin, they represent 12% of the population in Sri Lanka versus 1 to 2% in Europe. So there is a really high frequency of that mutation in Sri Lanka. And you see here that we frequently say that Sri Lankan and South Asians have the same, when looking at South Asian Asia, we can guess Sri Lankan data, but you see here that the frequency was quite different of that variant in Sri Lankan and in South Asian. A previous study performed in a smaller population tried to look at differences that they might be between Sri Lankan populations. So they compared Sinhalese, Tamils, and Moors. And regarding SLCO1B1, they couldn't find a huge difference between the three communities. So what is the impact of SLC01B1 on statins? You see here the impact on the exposure to statins. And you see that there are differences between the statin. You cannot say if my patient carry a SLC1B1 mutation, all statins are banned. For some statin, the impact is not huge, like for fluvastatin, rosuvastatin, and pravastatin, it's okay. But for simvastatin, pitavastatin, and atorvastatin, you see that there is a huge increase in the exposures to statins. And a meta-analysis looked at all the studies done on that gene and statin-induced myopathies. And overall, the presence of that mutation increased the risk of all myopathies by a factor 2.3 and severe myopathy by a factor 3. But when looking only at simvastatin, you see that the odds ratio can go up to almost 6 for severe myopathies. So this is why some authors recommended dose adaptation for statin based on the genotype. And you see that for those drugs whose exposure is highly impacted by the genotype, they suggest a reduction or by 4 times of the dose of simvastatin, pitavastatin, and atorvastatin, while for fluvastatin, there's no dose adjustment. But more recently, some guidelines were released. So the European Society of Cardiology in 2022 released a guideline regarding pharmacogenomic recommendation. And they stated that high-dose simvastatin 80 milligrams should be avoided in carriers of SLC01B1*5, and that an alternative statin should be chosen. But they even recommended prospective genotyping, so performing a genotype before simvastatin initiation. The same year, the CPIC consortium released guidelines that have to be read in conjunction with the American College of Cardiology and the American Heart Association guidelines. In 2018, they released the guidelines for cholesterol management, where they classified statins into high, medium, or low-intensity statins based on the expected ranges of LDL lowering that you are aiming. So if you want to use a high-intensity statin in CYP2, in SLC01B1 poor metabolizer, rosuvastatin 20 milligram is fine, it's a low risk, but there's a high risk, so those statins should be avoided. Atorvastatin 40 to 80 milligram, rosuvastatin 40 milligram. The same recommendation was done, so the same type of recommendation for moderate intensity and low intensity statin. You see the statins that can be used with low risk, with moderate risk, and the one that should be avoided. And also recommendation for heterozygotes carriers, so carriers of only one mutation. The third example is the example of the anticoagulant warfarin. You all know that drug. And warfarin is associated, unfortunately, with several adverse drug reaction, bleeding in particular. So warfarin has also been quite studied in the field of pharmacogenetics. And you see here the main pharmacogenes that are important in response to warfarin. CYP2C9, so a cytochrome P450 that converts warfarin into an inactive drug. VCORC1, which is an enzyme that's inhibited by warfarin. And cytochrome P450-4F2 that converts vitamin K into an inactive vitamin K. These 3 targets can explain variability in doses of warfarin. You see here that carriers of one mutation of the VCORC1, they need reduced warfarin requirements. Carriers of mutation of CYP2C9, reduced warfarin requirements. And carriers of mutation of CYP4F2, they need higher warfarin. And overall, these 3 mutations, they almost explain 50% of the dose variability of warfarin. There are other mutations than those listed here. In particular, for VCORC1, there are also mutations that explain higher warfarin requirements. And I show you here the frequency of those variants in the Sri Lankan population. And you see that the CYP4F2 variant that explains higher doses of warfarin is really prevalent in Sri Lanka, almost 50% of the population, while in Europe it's only 28%. The VCORC1 mutation here, it's not the mutation that requires lower dose, but that's a mutation that requires higher doses. So again, almost 50% of the population. So in Sri Lanka, certain amounts of people need higher doses of warfarin than the usual doses. And you see here that there are differences between the Sri Lankan population with, if you look here at the VCORC1 mutation, that explains lower doses of warfarin. You see that the Tamils, they have less frequently that mutation than the Sinhalese. So there are some differences between population. So what is the impact of those mutations on the warfarin response? This is a study that was published in 2013, a multicentric study, pragmatic, single-blind, 455 patients with atrial fibrillation or venous thromboembolism that were initiated on warfarin. And the authors did two groups, one genotype-guided group. They were genotyped for CYP2C9 and VCORC1, and a control group. The primary outcome was a % of time to target INR over 12 weeks. So that study showed that in the genotype-guided group, the percentage time in the therapeutic range was higher than in the control group, 67.4% versus 60.3%. They showed also that the INR that were too high, above 4, were reduced in the genotype-guided group, 27 versus 36%. And the time to reach therapeutic INR were also reduced, 21 days versus 29 days. So a positive study that showed the importance of having the genotype to reduce the risk of warfarin over-treatment. Another randomized clinical trial, multicentric, in elective hip and knee arthroplasties. This time the patients were genotyped for VCORC1, CYP2C9, but also for CYP4F2, that gene that's quite prevalent in Sri Lanka. Again, genotype-guided versus clinically guided warfarin dosing. And the primary outcome was composite, major bleeding, INR above 4, venous thromboembolism, or death. And again, the number of events in the genotype-guided group was reduced 10% versus almost 15% in the clinically guided group. The number of INR above 4 was reduced, relative risk of 0.71, and the bleeding risk was also reduced with a relative risk of 0.24. So, if you have the genotype of a patient in hand, how can you guess the dose that you should give to your patient? There are actually guidelines and dosing algorithm available online. So if you know the genotype of your patient and that the patient is not from an African ancestry, you can use a dose adaptation algorithm that's available online. You type the value of the genotype on top of the demographic and clinically important factors. You see that the interacting drugs are also taken into account. And if you want to know more details, that's quite complicated, but you see what factor is applied for which factor. But overall, some authors have guessed the doses that Sri Lankans should receive based on the prevalence of those different mutations. And you see that overall, the population of Sri Lanka should receive 75% of the population would require high warfarin doses, as compared for Central European, it's almost 50%. But you see that it's quite different from the Chinese and the Malaysian. So these were 3 examples where you see that pharmacogenomics already has an impact on clinical care. But you have to know that there are currently 20 genes whose variants have an impact on more than 100 drugs. Almost 20% of drugs on the market are affected by actionable pharmacogenes in different fields, in pain, cardiovascular disease, cancer, infectious diseases, psychiatry, transplantation. And it is estimated that in the next 4 years, 50% over 65 will receive a treatment that could be optimized by pharmacogenomics. So again, you have on this website, on the PharmJKB website, all the guidelines from the Dutch, the US, and the Canadian working groups on pharmacogenomics. And currently, there are 188 clinical guidelines annotations. But the question is now, why do we have to wait to have an adverse drug reaction or a drug that's ineffective to do a pharmacogenetic test? Shouldn't we have the DNA sequence already in the medical record to simply, by a click of a mouse, directly give the right drug to the right patient? Meaning having preemptive genotyping. And that's what some European consortium wanted to know by doing the UPGX PREPARE study, preemptive pharmacogenetic testing to prevent adverse drug reactions. They wanted to know whether, if we genotype before giving any drug, we are able to reduce adverse drug reaction. So that was a study published last year, an international study, genotype-guided versus standard care treatment, more than 7,000 patients. In the genotype-guided group, the patients were genotyped for 12 genes and 50 mutations, and the primary outcome was the occurrence of clinically relevant adverse events. And interestingly, that study showed that in the genotype-guided group, adverse drug reactions were reduced by 30%. There is currently a pharmacoeconomic analysis going on to see whether it is worth doing those genetic tests. The answer is probably yes, because the adverse events have a cost. But this is a step towards better implementation of pharmacogenomics in Europe. So pharmacogenomics is important, but you have to remember that our genome interacts with our environment to determine our phenotype. And in Geneva, we believe in pharmacogenomics, but we also believe in phenotyping, because when you predict the phenotype from the genotype, you might have a mismatch between what's predicted from the genotype and what's the real phenotype of the patient due to environmental factor. And that is what's called phenoconversion. Phenoconversion is the discrepancy between the prediction of the metabolism based on the genotype and the actual ability to metabolize drug due to non-genetic factors. When doing a genotyping test, one looks at the genetic mutation only. When doing a phenotyping test, you take into account all the other environmental factors. So in my university hospital, we have developed what's called a phenotyping cocktail to phenotype for different cytochrome P450s. The way we do that is that we give what's called probe substrates, so specific drugs specifically metabolized by certain enzymes. And after a certain amount of time, we measure in blood or in urine the concentration of those probes and their metabolites. There are 2 conditions to give a phenotyping cocktail. The enzymes have to be selective, and there shouldn't be any interactions between the substrates. So the Geneva cocktail is made of 6 probes, specific for each of these cytochrome P450s. So we administer caffeine, 50 milligram, bupropion, fluorbiprofen, omeprazole, dextromethorphan, and midazolam. 2 hours after the intake of these microdoses probes, we measure on a dry blood spot the concentration of these 6 substrates and their metabolites, and this gives us the real activity of these 6 cytochrome P450. That method is very easy to use because the dry blood spot, the paper, can be kept at room temperature for a month. So this can be sent by post. It doesn't have to be stored in a fridge. So we can do phenotyping in medical practices and also in different countries. We've conducted an international studies where the phenotyping was done in the country, and then it was simply sent by post. So why did we do the phenotyping and genotyping in the clinic? In 38% of the cases for inefficacy of a medication, in 1/3 of the cases for toxicity. You see the drugs that were mainly involved: psychotropic agents, analgesic, cancer agents, immunosuppressant, and cardiovascular drug. And interestingly, out of all these tests we performed, 56% of cases found an explanation in the genotypic test. So we could explain why there was drug inefficacy or side effects due to the genotyping. But when we were combining genotyping and phenotyping, we were able to increase the explanation of the cases to 71%. And we published several case reports of patients who had adverse drug reactions due to this polymorphism, just to show you that when you think about it, you found the cases. So these were just regular cases that came to the hospital. The first one, it was an intoxication to codeine, a patient that was taking codeine as for cough, so it was really a small dose. That patient was a CYP2D6 ultra-rapid metabolizer. He had to go to ICU due to opioid intoxication, but if nobody thinks of those polymorphism, nobody looks at them, and we cannot find those explanations. And what's interesting is that when we look at the genotype that's measured and the genotype that's predicted from the genetic test, you see that in poor metabolizer for CYP2D6, there is a 100% concordance. But the higher the activity of CYP2D6, the lower the concordance. Only 38% of normal metabolizer were correctly predicted from their genotype, and only 20% of the ultra-rapid metabolizer were correctly predicted from the genotype. In 1/3 of the cases, drug-drug interaction could explain that mismatch between genotype and phenotype, but in 70% of the cases, we found no explanation. So one obvious explanation is that there are genetic mutations that are not looked or that are still unknown. But more and more, we know that diseases themselves can have an impact on the activities of drug metabolizing enzymes or transporters. And in Geneva, we're interested in inflammation. So we looked at the impact of inflammation, both after surgery and also after SARS-CoV-2 infection on the activities of CYPs. So in the first study, we administered the Geneva cocktail before hip surgery, 1 day, 2 days, 3 days after surgery, and we measured the activity of all the cytochrome P450s. We were able to show that there was a correlation between the level of CRP, of C-reactive protein, and CYP3A activity. The higher the CRP, the higher the decrease in CYP3A activity. And the numbers are small here, but I will go through them with you. If we look at CYP3A, CYP2C19, and CYP1A2, after 1 to 3 days after surgery, you see that there is a decrease in the activity of those 3 CYPs of 53 to 61%. For other CYPs, the activity is increased, and for other CYPs, there's no modification. But this is another way to show you the results. You see that, let's talk about CYP2C19. You see that 3 days after surgery, 82% of patients who had the surgery, they changed their phenotype. Based before surgery, they were normal metabolizer, they became poor metabolizer, or before surgery, they were ultra-rapid metabolizer, and they became normal metabolizer. So the disease itself modified the activity of cytochrome P450s. For SARS-CoV-2 infection, we measured the activity of CYPs during the infection and 3 months after the infections in 30 patients. And we were able to show the exact same thing. CYP1A2, CYP2C19, and CYP3A, those 3 CYPs, the activity was reduced during COVID infection. And 3 months after, the activity went back to normal. The same 2 other CYPs, CYP2B6 and CYP2C9, the activity was increased. And for CYP2D6, no modification. And again, you see that the patient, they change their phenotype. For CYP2C19, 50% of patients, they change their phenotype during COVID infection. This is important to know because you may have a patient who has a regular treatment, let's say a statin, is fine on his statin. During COVID infection, the activity of CYP3A is reduced by 41%. It's as if the patient was receiving a CYP3A inhibitor, so there might be an increased risk of myopathy during that acute infection. So I've shown you some advances in pharmacogenomics, but this is just the beginning. More and more pharmacologists are interested in what's called pharmacoomics, because we look at genomics, but we can also look at RNA, transcriptomics, at protein, proteomics, and at metabolites, metabolomics. In my hospital, we are interested in metabolomics. We've developed that Geneva cocktail, but the Geneva cocktail implies administrating exogenous probes. So patient has to take microdoses of drugs in order to be phenotyped. The next step would be to be able to phenotype with endogenous metabolites without giving any exogenous substances to have the real activity of the CYPs. So we started with CYP2D6. We enrolled 42 healthy volunteers. They were genotyped for CYP2D6. They were phenotyped with the Geneva cocktail. And they had to participate in 2 sessions. A session where they did not receive any treatment, and another session where they received a CYP2D6 inhibitor, an antidepressant called paroxetine. We did metabolomic analysis, and we were able to identify 5 endogenous metabolites that were significantly decreased during the inhibition session. We then wanted to identify what those 5 metabolites were, and surprisingly, we found that those metabolites were solanidine and metabolites of solanidine, and solanidine is actually a glycoalkaloid found in the potatoes. So the consumption of potato is so wide, and we thought we found an endogenous metabolite, but in the end it was an exogenous metabolite. But this solanidine is actually a substrate of CYP2D6, and this is very small, but before and after paroxetine, solanidine and the metabolites were statistically significantly modified. And you'll see in the literature more and more solanidine being used as a way to assess CYP2D6 activity without having to give any exogenous substrate. And this is quite handy if you have collected samples. If you have a biobank, you can retrospectively assess the real CYP2D6 activity on top of the genotype. And of course, doing the phenotype is less expensive than doing the genotype. So all these omics technologies, the biomarkers of drug response, on top of the usual factor we take into account, family history, medical history, lab values, comorbidities, drug-drug interaction, lifestyle, they should allow us to better predict drug response. And all this in conjunction with electronic health record, they could help us guide our treatment decision in a better way in the future. One of the problems is the pharmacogenomic knowledge. When we ask physicians whether pharmacogenomics is interesting, of course, 98% believe that pharmacogenomics could help them better predict treatment response, but there is a lack of knowledge. Only 10% of physicians consider their knowledge and available and tools adequate. So what we are doing in the clinics is we are developing clinical computerized decision support. When a patient is prescribed codeine and we know that he is ultra-rapid metabolizer, there is an alert saying find an alternative to that drug. We have also developed an online course, a massive open online course in precision medicine. This is totally free on the Coursera platform. So if you are interested in that field, you can follow that course for free. We also believe that patients need to be better informed, so we give them a wallet card with their genotype, their phenotype, and with some drugs they need to be careful with. So giving them drug information and dosage, and why not in the future giving that card to the pharmacist. This is my pharmacogenomic profile, and the pharmacist should also be able to advise the patient in the same way as he advises the patient for drug allergies. So the promise of pharmacogenomic is really to improve therapy outcome, to reduce treatment duration, reduce treatment cost, reduce the incidence of adverse drug reaction. But in the future, the question will no longer be whether to prescribe a test, but how to use the existing genomic test results. I've shown you that there are diagnostic tools available, phenotyping, genotyping. Those are complementary approaches. I hope I've shown you that phenotyping is a good way to take into account both the genetic, known and unknown variants, environmental and disease factors. It is the only tool to enable phenoconversion to be measured, and some of the drawbacks of phenotyping have already been overcome. So it is becoming a method of choice in the clinic to accurately measure CYP metabolic activity. The outlook is to increase awareness and education, to increase clinical implementation for physicians, pharmacists, and patients and nurses, to develop clinical decision support tools when electronic health records are available, to provide additional training and capacity building in genomics, in particularly in low and middle income countries, to conduct pharmacogenomic studies in non-Caucasian population, because most of the guidelines are based on the alleles that are frequent in Caucasians, but I've shown you that, for example, in Sri Lanka, some mutations are not the same, so pharmacogenomic studies have to be conducted in different populations. We need a better understanding of the interaction between gene, environment, and diseases. In the future, we will look at other omics technologies on top of genomics to discover new genes, new therapeutic targets, novel rare variants, and new biomarkers and omics signature to predict drug efficacy and toxicity. But of course, this will need cost-effectiveness evaluation to assess clinical validity and utility. But I hope you understood that with these tools, we can become more clairvoyant when prescribing drugs to our patients in order to give them the right drug at the right dose. And I will finish with this quotation from Hippocrates, who said that it is more important to know what kind of person has a disease than to know what kind of disease a person has. So he knew already years back the importance of precision medicine. And I will finish with this picture I took in Kandy to wish you good health, and I thank you for your attention.
Thank you, Professor Samer, for that excellent oration on the present advancements in personalized healthcare and pharmacogenetics. To express our gratitude, I invite Professor Priyanka Ranasinghe, Secretary of SLACPT and Professor in Pharmacology at the University of Colombo, for the vote of thanks.
Thank you very much. A very good morning. Professor Simon Maxwell, guest of honor, Professor Caroline Sama, our orator, Professor Priyadarshini Galapatti, President of SLACPT, members of the Council, distinguished invitees, ladies and gentlemen. On behalf of the Sri Lanka Association of Clinical Pharmacology and Therapeutics, I want to sincerely express my gratitude to everyone who played a crucial role in making Clinpharm 2024 a success. Firstly, a big thanks to Dr. Palith Mahipala, Secretary of Health, Sri Lanka, for agreeing kindly to be the chief guest at this occasion amongst his busy schedule, and also for the unwavering support that the ministry has given the association right throughout in the numerous activities. I also appreciate Professor Caroline Sama from the University of Geneva and President-elect of IUPHAR for collaborating with the SLACPT and facilitating for all the foreign delegates who will speak during these sessions to be here. In addition, thank you so much for the excellent oration. Being a personal area of research interest, I found it quite interesting, the volume of research work and the innovation you have done in the area of pharmacogenomics. I would also like to thank Professor Simon Maxwell from the University of Edinburgh and the British Pharmacological Society for being our guest of honor and supporting our efforts to enhance prescribing safety in Sri Lanka. And I think all of you who were there yesterday at the pre-Congress session workshop would have found it interesting. And we hope that you will continue to support us during our endeavors to introduce the prescribing safety assessment in Sri Lanka. Also, I would like to extend our gratitude to Dr. Ananda Vijayavikrama and the National Medicines Regulatory Authority who are supporting us in organizing the post-Congress workshop on rational and cost-effective prescribing. In addition, I am really grateful to Professor Vajira Disanayaka, the President of the Sri Lanka Medical Council, Professor Rohana Marasinghe and the team from the internship committee for the support they have extended in making the PSA a reality in Sri Lanka. A special thank also goes out to Dr. Sagari Kirivandeniya and the team at the Colombo South Teaching Hospital for their help in organizing another post-Congress workshop, the medication safety site visit, which is scheduled for the 13th, to showcase the medication safety practices that are being currently done in Sri Lanka. Also, we appreciate the World Health Organization for their support in facilitating the participation of foreign delegates, the National Science Foundation, who kindly sponsored the printing of the proceedings book and also essentials for the audiovisual support. I must also thank all the presidents who are here representing the colleges and also thank them for their participation and collaboration with the SLACPT in developing the various guidelines which will be presented at the post-Congress workshop on rational and cost-effective medicine use, enriching the post-Congress workshops. We are thankful to all the resource persons who are here for sharing their expertise. I thank the team at the BMICH for their invaluable assistance in organizing this event. In addition, I would like to thank the authors who submitted the scientific abstracts, Professor Pradeepa Javardhana, the panel of reviewers for their diligent work in reviewing and judging the presentations, and also to Professor Pradeepa and Dr. Chiranti for getting the proceedings book ready. In addition, I acknowledge Dr. Sujivani Kurukuru-Surya, Leonard, and the team for managing the finances of the conference, and all the council members who have helped in numerous ways in making this Congress a success. I also appreciate Mr. Amal Ranawaka for the photography and the AV team, and also the Colombo University Press for printing this book on time. And I would like to express my gratitude to Ms. Angela, the volunteer who did an excellent job in being the MC at the event, and also to Doctors Minura, Ajanti, Mathura, Pulasti, and Chintani who had done a lot of hard work behind the scene. If not for them, I'll be still at the department running around getting things organized. Thank you very much. Mrs. Priyani, Inoka, and Supun, who have helped immensely in arranging this work. Finally, to all the delegates, both local and international, thank you very much for being here with us and sharing your expertise. And I hope that you enjoy and join in the proceedings that we have listed in the program. Thank you very much for being here. Thank you.
Thank you, Professor Ranasinghe, for appreciating the hard work of all those who made this conference possible. Ladies and gentlemen, we have now come to the end of the inauguration. Please rise as the procession leaves the hall.